it is possible. Yeah, a lot of planning goes into these kind of events, so thank you. And that's a good segue into the fact that, you know, we just started this semester, but it's going to be over soon, and we're going to have a whole new board in the fall. So if any of you guys are interested in being a part of this team, it's really an awesome experience. It looks good on Rodax, looks good on resumes, it's just fun. So we hope you'll think about joining us. And then I want to thank the speakers. Two of them are here, one's on her way. So we have Barbara Lang, we have Dr. Rama Krishnan from our department, and then we have Monica Wheat from Holy Cross, who will be here soon. We're very excited to hear from them.
Hello. So before we get started, we just have a couple of housekeeping rules. So when you are done with your food, we ask you to please throw all your trash away. There's a trash can right there. There's also some outside. Second, we like to mention that at the end of the presentation, at the very end, we like you to exit through that door, the back door. But if you are a NSSLHA member here for points, you can exit through this door so you can sign out. So that's something we're starting. We ask you to please stay through the whole presentation so that you may get your points. So you can sign out with Sarah, our treasurer, outside.
Okay, and then for the actual presentation, there's going to be about 5 minutes between each presenter. It's going to be really short, so that's the time where you're going to sprint out and go to the bathroom, get more food, whatever you need to do. We keep a pretty tight schedule for this event because we want all of you out of here at a decent time. It's Friday night, so we hope you can cooperate with us and not, stampede or anything. So yeah, I think we're good to go. So our first speaker, Barbara Lang.
This is the 5-minute break.
Okay. Can you hear me? Okay. Welcome. I'm talking about adult apraxia and aphasia. Of course, I always like some humor, so I have some pictures of dogs, which I the speech dog teaching the little dog who says meow how to use dog language, bark, growl. And down here, this was a really cool series. There was a comic strip called For Better or Worse. They had a whole series on the grandpa that had aphasia. And if you ever want to just kind of Google that, it's a fun place to look. But it's talking sort of what it feels like to be able to want to talk. The speech therapist saying, try me, moo. Okay, wash my mouth, me, moo. Again, me, meow. With the M sound, me, mom, almost me, la. So that's typical of, which disorder would that be typical of? It could be a vocal aphasia or just that's the apraxia. He's trying, but he can't get the sounds together. Okay, so my case is a 38-year-old bilingual English and Spanish female. She was a manager in the food service industry, married 3 years, and her husband speaks primarily Spanish. She has 2 children, 8 and 12, from the previous marriage. Her medical history includes hypertension and diabetes. And in social history, she smoked a half a pack of cigarettes every day for about 20 years. I'll just tell you, that is a bad combination. You'll see that a lot. You'll see that a lot with any sort of neurological or even other disorders. She was room mother for her younger child and loved socializing with her friends, dancing and reading. So RO had gone to work early to do some paperwork in her office. When her coworker entered about 8:45, she found her on the floor. She looked at her friend and said something, but it didn't make sense. So her friend called 911. What do you think might have happened? Could have had a stroke. Is that the only thing? I know obviously you think it's a stroke, but what else could have happened? She could have had a heart attack. She could have tripped and fallen on the desk and hit her head, had a traumatic brain injury. Low blood sugar. Very good. Yeah, could be low blood sugar because she's diabetic. So that's fallen hit her head on the desk. Had a medical problem like a heart attack. She could have passed out from drugs or alcohol. Who knows? Might have been hypoglycemic from not eating breakfast, or had a stroke. Good, you got all those answers. Terrific. She was admitted to the hospital emergency room. She presented with a right-sided weakness, pretty mild, appeared confused, but followed some simple commands. Fine.
I'm sorry to be rude.
Welcome. She followed some simple commands like squeeze my hand. Why do you think she was able to follow that command? I'll throw that in. If she's kind of alert and the doctor comes in and says, squeeze my hand, it's sort of an automatic movement. It's not really telling her anything that she really has to process because her hand's there. She focused well on people speaking to her. She pointed at things and made sounds, but was unable to answer questions. She would begin crying for no apparent reason. She was sent to the CT CAT scan. No bleed was observed. On here it shows that she had a right frontal parietal sort of lesion. In that area, what kind of thing would you expect? There's a drug or it's a protein they give called TPA. She was considered for TPA, which is tissue plasminogen activator, which first clot. You can't give it if she has a bleed, but if it's only a blood clot, it sometimes makes the stroke disappear. It clears up the blood clot. But they didn't give it to her. Why do you think they didn't give her that miracle? No, that wouldn't prevent her. Her medical history would not be prevention. But when did they find her? When the co-worker came in at 8:45. Do we know when she came, how early she got to work? Do we know when this happened? With TPA, you can't give it unless you know it's within 3 hours. So because they didn't know when it happened, they couldn't give that to her. She was transferred to the intensive care unit where she was evaluated by speech pathology, occupational therapy, and physical therapy. When she's in the ICU, what kinds of things would an SLP look at? Swallowing? Did I hear that?
Yeah.
Yeah, probably the first thing would be swallowing because that's sort of the most crucial. What else would you do for cognition? What would you do for cognition?
She knows, she's aware.
Yeah. In ICUs, you can't do a lot of standardized tests by any means, so a lot of it's observation. What modalities would you make sure you sort of scope out to see? Who said that? Okay. She said, yeah. So you would look at her swallowing ability, her auditory comprehension. Does she seem to be following directions, asking yes or questions? Her verbal expression, what she's saying. Her reading. Is she reading signs in the room? Is she looking at the newspaper when you come in? Her written language. Is she able to write the name for you? And her cognition. Is she paying attention? Does she seem confused? Is she eating her eggs with the glass? Just confusion like that. So the non-standardized test was administered. She was attentive to the SLP talking to her and the activity that was in her room. Her face was symmetrical, no obvious paresis. She did not follow commands during oral peripheral exam for swallowing. The nurse stated that she had no problem eating her mechanical soft consistency lunch. Mechanical soft consistency just means if it were on the soft side, it's basically solid food. And it implies that she was drinking thin liquids without a problem. She followed 4 out of 10 motor commands, like look at the ceiling. She responded to yes/no questions by shaking her head inconsistently, but her expression changed when given the correct biographical information. She pointed to pictures named in 4 out of 6 trials in a field of 3 pictures. She did not imitate any oral motor movements or speech sounds. She made some mouth movements to respond, but did not speak. When she was presented with printed words, she slowly matched the word to the picture for 4 out of 6 items. She could not write her name or other words with her dominant hand. She didn't really have a weakness on that. Why do you think she couldn't write with her right hand that was her usual writing hand? She may have had motor planning problems with doing that. But she was able to copy some shapes and letters with mild to moderate distortion. Also, why could she not write it? There may be some component of aphasia in here as well. She was discharged home with her family after 1 week. Ooh, seems fast. But because she was medically stable and could walk with standby assist, meaning she just needed somebody near her, she could go home. She appeared to be understanding more and would laugh at her children's stories, but was not talking at all. She began outpatient therapy with speech and OT 3 times a week and with PT twice a week. PT only lasted a couple weeks, speech and OT went on for a longer period of time. After 10 weeks with the speech therapist, the frequency was reduced to twice a week, but she remained in outpatient therapy for 8 months. An evaluation tool was administered. Again, we didn't use a standardized test, but the evaluation screening tool incorporated portions of the Boston Diagnostic Aphasia Exam and the Minnesota Test for Differential Diagnosis of Aphasia, and many non-standard measures with observation of what her responses would be in each of the modalities. She was accompanied to the eval by her husband, who spoke broken English. He stated that RO spoke English fluently with the children and at work, but she communicated with her husband and other family members in Spanish. The assessments were presented in both English and Spanish, with no significant difference in her response accuracy. So it's whatever is presented, whichever language, she has the same problems. So from the assessment, she followed 1-step commands, 60% accuracy, like clap your hands. Simple yes and no questions, she was 80% accurate with the gestural response. That could be a yes, no, or whatever way to kind of indicate, that's right. But you could tell that she was giving the correct response. She answered yes, abstract yes, no questions with about 70% accuracy, and she self-corrected, like, do horses fly? She might be delayed, she might start to say, and then she would give you a no. She pointed to pictures named in a field of 10 pictures now with 90% accuracy, with some delays and self-corrections in her responses. For verbal responses, she was nonverbal, rarely made any vocalization, no spontaneous words were elicited. She did not imitate oral motor movements such as open your mouth or stick out your tongue, even with visual cues. She could not produce automatics such as counting or sing happy birthday, but when they sang happy birthday, she conducted it, waved her hand and smiled. Reading, she was matching single words to pictures in a field of 10 with 70% accuracy, and she matched short phrases to the picture with 40% accuracy. And she identified the answer to personal questions given 3 choices with 70% accuracy. Writing, she copied letters with distortions with her dominant hand. She attempted writing her name and correctly wrote 5 out of the 7 letters in her name. And she wrote a few letters correctly in naming single pictures, like DOM for dog. Close. And cognition, she was attentive and appeared oriented. When asked, who is that man? She smiled and pointed to both of them and then pointed to her ring finger, indicating. Did she know the question? Did she have sort of a complex way of processing it? She didn't just look at you. She made the connection of this wedding ring. So her cognition was pretty good. And her problem solving in context, like when given a pen upside down, she turned it the right way and turned it on. If people are having some reasoning problem solving, sometimes even that is challenging for them. Oh, sorry. So, what is your clinical diagnosis for RO? Does she have dysarthria? No. Why? How do you know that? Prove it. Why do you think she doesn't have dysarthria? What is dysarthria? Motor problem. What kind of motor problem? Yeah, it's weakness. So what proved to you that she didn't have dysarthria? She could eat without any problem. There was no drooling. There was no facial asymmetry. Does she have aphasia? Yes. Yeah. Does she have apraxia? Yes. You could kind of guess big time she had apraxia. And cognitive impairment? Minimal. So we talked about the dysarthria was not present. She was eating food. Mild to moderate aphasia was evidenced by inconsistent accuracy in auditory reading and writing modalities. Her expressive language really couldn't be effectively assessed because she couldn't really respond, but she would try to indicate that she was trying to say something, appeared to know what she wanted to say, and use facial expressions and gestures to try to express that. She has severe oral and speech apraxia, evidenced by the lack of vocalization, her inability to imitate oral movements and words, and random mouth movements in an attempt to talk. So this is sort of just an example of her course of treatment. For auditory comprehension, we practiced graded auditory exercises, increasing in length and complexity. She improved her ability to respond to complex directions and yes/no questions to about 95% accuracy. She occasionally would request repetition of stimulus due to mildly slow processing. And she used a lot of environmental cues, such as gestures in conversation, printed words, or inflection of speech to kind of increase her comprehension. So was her auditory comprehension significantly impaired? She kind of could get by. For reading, we did graded exercises from word to moderately complex sentences, and it improved in her comprehension to 85% accuracy. Reading words aloud improved to 50% accuracy with frequent phoneme errors. So she tried, but couldn't get the words. She indicated she practiced reading captions in magazines when the pictures were present. So she knew that she could read and understand things, but having a picture, like in People magazine, she'd see a picture of something and be able to read the caption because she had an idea from the gestalt of what was going on, what it might be saying. She communicated with friends by text for simple social interactions, such as a friend asking, do you want to come over? And she often used text to speech to understand the messages and emails that she didn't quite understand. So she was utilizing her phone as a communication device already. And she figured out that, oh, there's this thing on there that can talk for me. So she was pretty technology savvy as far as that goes. Written expression, she improved writing her biographical information with moderate delays and self-corrections to 85% accuracy. She wrote single words with delays and self-corrections with 70% accuracy. She started writing common short words such as I love you, or short phrases, with delays and self-corrections about 50% accuracy. And she responded to text with a short response like, I'm fine, how are you? But she would often use word prediction when she couldn't get the spelling of a word. So verbal expression. Think this is the biggest problem? Just getting anything out of her mouth is the big problem. So the others were worked on concurrently, but this was really the strongest focus of her therapy. When she came in, she was not able to produce ah on command or imitatively. Using a mirror, the clinician modeling, and visual and tactile cues, she learned to open her mouth. We would like tap to get her to go open, and she sees herself in the mirror, open her mouth. To get her to vocalize, we put her hand on my throat, her throat, and just ah, on and off phonation. Then we progressed to other vowel projections with the same looking in the mirror, visual cues, tactile cues, to broaden her spectrum of sounds. And then we began with some constant imitation the same way. So we practiced just basic oral lingual kinds of exercises. This is what you might do in an oral proof exam, but she couldn't figure out how to motor plan to get those movements going. So sticking your tongue out, I mean, we did a lot of having like a lollipop there, and she'd have to follow the lollipop out. Or, smiling, she of course would smile spontaneously, but to do it on command, she needed tactile cues to do that. She was instructed to use her voice, even though she couldn't talk, to just let it out and try to say things around the house whenever she can. The more she just vocalizes, trying to say things, who knows what's going to come out incidentally. And then when she would accidentally produce a word or a sound, we would practice it several times with a volitional repetition, and then try to put it in another real context for her to be able to say it again. And of course, initially it was very hit and miss whether she got it, but that became more consistent as time went on, that she was able to reproduce it. So here's an example. You might have remembered this. This tells where, the placement of producing the sound and the manner that you produce the sound. From your phonetics class, what do you think she had problems with? Do you kind of logically think, bilabials, you think? Yeah. Developmentally, that's true, but she had the easiest time with alveolar sounds because it's just kind of where she automatically went. So no and to were some of her earlier words. The stops, like okay, were her easiest. 5-minute break. What? No.
Check. Great. Links. Yeah, there. So that's how we test hearing aids. By the way, I'm audiologist and I'm still professor here. So that's how we get started to grab your attention, by the way. Great. So I have a big topic. Probably takes 2 semesters to learn everything on these slides. My job is to compress it and make sure that you don't sleep on me. Okay, so let's get started. Let me get started. So, extreme disclaimers. I definitely need questions from you. If not, you'll be having questions from my side. So, don't worry. Don't bother to ask me questions. Okay. So, first question. I get started with questions. Who takes case balance? Which professional starts with balance? Does actually balance belongs to CDS, communication disorders and sciences? Sure. Communication disorders, audiologist. Okay, great. I'm really glad that you know that. Because not all healthcare professionals don't know about balance. Great, so that's a great start. So let's get started with this. Yeah. So how many of us ever had any dizziness or any kind of balance impairment? Wow. Oh my God, you can be all my research subjects. I can pay you some money for that. I'm just kidding. That's great, actually. So this is where I'm actually trying to get started with. So sometimes we feel like balance or vestibular disorders is mostly for adults or like a really older people. But that's a myth, actually. And it's same for hearing. People think that, oh, only old people will get hearing loss, but that's not true. That's a myth again. Most of the young generation actually have balance and hearing problems. So here, today, I'm just going to talk very fast, not too fast, and then just give a little bit about how exciting the vestibular system is, and probably I'll try to grab a few of you to audiology. I see I'm really jealous that most of you are speech. So my job is try to stimulate you or probably motivate you to see the puppy there. Great. So we have so many hands on vestibular disorders, but can anyone tell me if it's not violating HIPAA, why do you have or why did you face these balance issues? Okay, so let's talk at the end then. So right now we saw that the dog was completely like jumping and he was like saluting or rolling, right? So this is the condition. If we ask this dog do its natural activity, he's trying to soothe us, probably to reinforce you, to gain some advantages of you, probably get a snack, and he rolls down. That's his natural way of doing. So we don't realize how important the balance system until it goes away. So we know how it affects our hearing, right? So if it goes away, can we live in a regular world? Can you do your normal activity? It's actually yes. There's a whole different community that they don't hear anything and they don't want to hear a thing and they do live normal everyday life situation. But think, what if you don't have any light? Like all 365 days is completely dark, no lights, no electricity. Can you walk? No, right? So think the vestibular system the same way. If once the vestibular system gone, you can see this dog is active now and then it's gone. It can't do its everyday activities. So the balance system is really important than hearing, and please, no offense, important than speech. No offense there. Okay, so that's the reason why the balance system is really important. But the most embarrassing is that we overlook the importance of balance. Not even all healthcare professionals don't realize the importance of balance. I don't know how many of you who raised your hand, if you approach me, your primary care or ENT or neurologist, most of the time, people or medical physicians give you meclizine to reduce your balance, which makes you feel sleepy. You sleep for 2 days and then you feel like, oh, fine. And then it comes back again. But that's not the treatment. It's because it's really overlooked and we don't realize the importance of it. So my job is advocating vestibular disorders and make sure that we get the right treatment for that. Okay, so let's get started. This is a whole 9 hours class for doctoral students, but I try to finish it within 4.5 minutes as fast as I can and interesting. So we all know this is cochlea, right? And this tiny scary part, I don't know if it scares you, but it scares me. So this tiny part is cochlea, and this is the vestibular system, and this is where we're going to focus. I'm pretty sure all of you have learned about cochlea. So this is the major part in our ear. So it has 5 different parts, and it's categorized into 2. The first category is the semicircular canals. It's based on its shape. You can see that it is actually canals, but semicircular. And then it has the anterior or superior and posterior, and the third one is the lateral. The second category is macule or maculae, and it is petricle and saccule. So what does it do? The cochlea is responsible for hearing, right? So it hears stuff, all kind of stuff, even though some sounds we don't need to, we do hear. So to again grab your attention, I have cute cow. Why stick the dog, right? So let's go with cow now. So it's going to demonstrate us what this vestibular system is going to do. So the first one, which is the first, so you see the cow is not mad here. It's actually doing its job. Right now it's demonstrating what does this 3 semicircular canals do. So it is responsible for, right now I'm moving, right? So why am I moving, right? Right, without falling down, is it my legs? No, it's actually my balance system. My balance system know that I'm actually walking on a stable and a carpeted floor. And my balance system can actually know if I'm walking on a hard surface or soft surface. Let's say if this is completely blind and if there's a step, if I'm going down and if I don't realize it, we always like give this jerk, right? That's not your body, it's your balance system that's actually responding to those kind of movements. And here the cow is actually showing all angular movement. If you do this way, it's actually these 3 semicircular canals that's detecting the angular movements and letting your body know that this person, your brain know that this person is not crazy, but he's just moving his head. So that's what it does. Then the 2 other parts is actually like linear motion. If I'm moving like this way, it's actually my petricle and saccule letting my body know or my brain know that this person is moving straight forward. The other way is that if you're on a plane and if it's like taking off, how do you know it's actually going up? You feel it, right? So it's not your eyes. Even if you close your eyes, you know that it's actually taking off. I am very scared. I just close my eyes. Oh my God, it's taking off. But I still feel that it's actually lifting off. It's because this is the culprit in my ear that it's too sensitive, and that's why I get scared. So this is how it actually works. Yeah.
Is that a scale picture, like the semicircular canals versus the cochlea? Is that about? I know
It's not a scale picture.
It's not. So it's not.
Yes, they're actually, when you do the anatomical structure, they are combined, and you cannot discriminate most of the time. No, it doesn't look that big, by the way.
Compared to the cochlea.
Yes, it's a hand drawn by one of the earliest physician, so it's not actual picture. Yeah. So now I want you to think the balance system as your phone. So here we have a pretty good phone, and what it's doing is we are flipping it, right? If you're watching a YouTube video in portrait mode, as soon as you flip it, your video, if auto rotation is turned on, it automatically becomes landscape, right? So it's doing because it has a sensor in it, right? The sensor, I don't know if you know it, it's actually gyroscope or gyroscope. That's what it makes you rotate it, so it senses the motion. It knows if it is in a portrait mode or landscape mode, but this is a digital technology. But do I have a chip? Do you have chip in your brain? No. So the balance system actually helps these kind of motions. Okay, so these are the sensors rather than gyroscope or chips in my mind. So if we just make a dissection, this is how it looks now. So you see the tiny sensors in here. So these are the sensors, which is made of these 3 sensors. Looks like this actually. It's fluid fill on either side. As you move, then the fluid movement actually excites the motions, and that's how it sends to your brain saying that you're moving. So those kind of stuff. And the sacral and ventricle is these two, and it looks like this actually. So these are crystals, like real crystals, calcium carbonate crystals. It can melt and it can produce by itself. And this is another sensors within our ear. So there's a lot, right? Okay, I am succeeded. No one is sleeping now. Great. So this is a normal activity. Let's say this is my vestibular system. Now it's functioning properly, right? So that's why as you flip the phone, it's turning by itself. Now let's have another phone. See what's going on. He flipped the phone. Does it turn? No, unless he touched it. He made it do it, right? So I want you to correlate with this. So right now the dog can roll everything, meaning that this dog has perfectly normal vestibular system. But once it has this dizziness, let's say vestibular system is gone, and that's how it's going to be. Unless you kick him, not kick him actually, give a vestibular rehabilitation or appropriate medication, then he can stand up back again. He's not going to freeze. But he'll do his routine everyday life situation. So that's how the balance system works, and we really don't realize how important it is unless we go it. So here I mentioned that it is really important. And there are so many people in our, even in this batch, in this group, we've seen that so many people raise their hand, right? And I say that once it's gone, we can't function, but all of these students are here, then probably I should be wrong, right? Probably I'm giving you the wrong information. So when something is really, really important, then that kind of sensation is not actually given to only one part. In this case, I say that the vestibular system is really important, but the brain knows that if vestibular system is gone, then this person is not going to be doing anything at all. So that's why it also relies on other parts of information. Let's say if my balance system is gone, then the people related to hearing, if I have a deaf, like a really severe hearing loss, I rely on lip reading, right? The same way vestibular system, if my vestibular system is weak or completely gone, it's going to rely on eyes. So if you see any people with vestibular, they're going to walk like this, like extremely straightforward. They fix on something and then they move really straight. But they can't move like as good as you move. So that's how the vestibular compensation works. So no one is going to really fall down and they're not going to come out of their bed. That's not really true. But there are a few situations where they can't move. That's going to be a different topic. And if you're interested, stop by my class. So that's the importance and how the brain compensates for the vestibular loss. So before going there, now I want you to do some demonstrations to yourself. So now I'm just going to turn my head to the left as far as I can, and I'm going to scan all the way this room. So, and then I increase my speed, so like this. I'm actually watching everything here. And then now I'm just going to look straight, but I'm moving my head. So I want you to demonstrate, sorry. No. So now I want you to try it. So first, try to scan everything. Now just focus straight, probably just look at me and turn your head. Okay, I think that's enough.
Feel it, yeah.
Okay, so does it feel any dizzy?
Yeah.
Okay, that's good. You have proper balance system. You have proper balance system. So the way that it works, the first time when you actually scan everything, you can observe that your eyes are moving along with your head. But when you're just looking at me, your eyes are straight, but your head is moving, as if your eyes are actually floating in your body, in space, right? So it's not attached. So the reason is that, one of the reasons it's doing its job is because your vestibular system is working. If your vestibular system is gone, that's the easiest way to find. You ask one of your clients to move his head fast and open their eyes, and then you see something called a movement, which is called Nystagmus. So this is one of the demonstration. Now I can show on our batch to see how vestibular system weakness looks like. So I have a video here. So now the client is going to move his head very fast, and then he stops immediately. So for us, we're not going to see any movement. It just stops as soon as you stop it. That's the normal communication between vestibular system and your eyes. But let's see how it looks like here. So he's shaking his head, and as soon as he stops, he's going to open his eyes. See that movement? So that is involuntary movement, and the client doesn't know that it's actually moving. So all the sensation that he feels there is like a blurriness. If he tries to focus on something, he just feels blurry for a few seconds. In normals, it doesn't happen. Your eyes just stops right away because it's know that you stopped because your vestibular system stopped moving. Whereas in this case, this person have vestibular lesion, so it's not working, so it cannot actually compensate. So that's why it shows and then slowly realizes based on your neck movement. As I said, your brain is really intelligent and it knows that this is not sending me any information. Why don't I rely on other aspects? So now because head moved, it's going to ask the neck muscles, are you moving? It says, no, I stopped. Okay, then it takes like a couple of seconds and the brain sends information to eye saying that, okay, your neck is not moving, stop now. So that's when it's slowly going to stop it. So I have a raise here, yeah.
Does this induce nausea for a lot of them?
Not all kind of clients, but there is a couple of tests which I'll show you there. When we are testing, it actually induces nausea, and there are like so many clients will throw upon you if you're not careful. If you take them to like a peak range, they're going to throw upon you, but you should be careful. Yeah. Okay, so that's the another really simple indication of the vestibular system weakness. Okay, so I'm not going to talk anything about this. I just have pictures here to just show you that the vestibular system is connected very deeply with eyes. So they both work together. If not, when you're walking, you cannot actually force, you cannot drive because you're moving, your road is not flat. It's better than India, but it's not that flat, so it's always bumpy. So your vestibular system has to be working in order you to drive or even to get your driver's license. You should thank your vestibular system now. So this is how it goes. Basically, every canal here, we talked about 3 canals, right? Semicircular, horizontal, and posterior. Each canal, when it's activated in different angles, it actually activates specific eyes. So if this is activated, it lets these muscles, so this is superior muscle, and this is inferior muscle, and medial lateral rectus, all these muscles are independently linked to each vestibular canal. So that's how the complication of vestibular system. So I'm just going to go through, I think we're running a little late. So far we understand the importance of vestibular system and how it is linked to our everyday life, as well as what happens if vestibular system goes away. So let's see how this related in a real world. I'm just going to focus here, even though I mentioned the 60 years, this can be actually equivalent to our students in here who raised your hands. So this client we saw probably in 2 years back. I was working in one of the neurologic institute. So this particular client actually visited us saying that, oh my God, I have a really severe dizziness, and there are a few situations where it feels like extreme spinning, room spinning, or I'm spinning. So this spinning, when you talk to someone like audiologist, if you say spinning, we're going to call it as a vertigo. It's a spinning sensation. That's a specific term for vertigo. So she mentions these changes, and sometimes it gets extremely worse if I'm getting up, or if I'm sitting down faster, or if I'm standing up faster. So in audiologist perspective, there will be only a couple of explanations for dizziness. Once we say spinning, that actually indicates, oh my God, so this person has this kind of vestibular disorders. But in this case, she's pointing out to several vestibular disorders. So if a client comes in and then says that there are symptoms throwing all over, like dysarthria, dysphagia, atraxia, and all stuttering, it doesn't make any sense for you, right? So these kind of symptoms is the same towards audiologist. So what is she pointing? So the audiologist or any physician will be actually in question right now. Okay, so I have some complicated case, let my head get straight. and get forward. So these are the symptoms that she have, and sometimes she have numbness, nausea, as someone asked. So it actually causes nausea. So, and then we took the history. She had a heart attack probably 2 years back. It's like 4 years now. And she had a history of multiple ear infections and PTSD. So she also had anxiety at one of her recent, probably in 2 years, she also visited emergency, and they had to inject the diazepam, which is anti-anxiety medication, which went fine. And she also noticed that the dizziness reduced with that medication. And when she reported the dizziness, first time she actually visited ENT, and he recommended meclizine, which is motion sickness and vertigo reduction. So it didn't work on her. So this is the case history, and then obviously there's like several examinations because she had a heart attack. She visited cardiology and all neurology, which is completely unremarkable. MRI was completely unremarkable, and all ENT, head, eyes, ears, throat was completely unremarkable. And then came to audiologist. So we were hoping that we might find some information on it, showcasing vestibular, but we didn't find anything. It's just auditory evaluation and tympanogram, all those kind of stuff. And then obviously the balance is vestibular system. So now our job is to run a whole diagnostic process of vestibular evaluation. So we took her through the VNG, which is something like this. So we have a picture here. So we put goggles on her, and then we do a lot of nasty stuff, ask them to move your head because we need to test your vestibular system. So the tests include oculomotor, positional, and Dix-Hallpike. So one of the tests, as I was saying, Dix-Hallpike, if a person have a real vestibular disorder, while doing Dix-Hallpike, they can actually throw up, and they feel extremely dizzy. Sometimes, why did you make me dizzy? I came here for dizziness problem, and you made me dizzy. But that's how the test goes, right? So, and then calorics, this is another nasty stuff. We put water in patient's ear, not just regular water, like cold water and warm water. We want to make the client suffer. That's never the intention. So basically it tells us how well the vestibular system is functioning, so that's the caloric. And then we do rotary chair. We tighten the patient to a chair and make them like a roller coaster. So that's a test, by the way. It's measuring the length of the canal. So we test that, and then it doesn't indicate anything. And then the fluid, which we saw like a fast shaking and make them dizzy again, which is we hit. And then the last one, CDB, which is a very fantastic equipment, which tells us this person is going to fall down. Is there any risk? So we ran all this stuff, and then it's completely unremarkable. So now I want questions from you. Then you can ask me now, then what did you teach me now? You said that if the balance, so she had complete dizziness, right? But none of the balance system is wrong. Then what could be the reason for this client? Then how do I approach this client now? So I ran thousands of dollars of tests. Now how do I face this client? Like what would be the diagnosis now? I really don't see anything. So think as your client now. She went to cardiologist, neurologist, and had an MRI, had ENT, neck, everything, and all those people indicate that. So you have vestibular disorder. And then she have high hopes when you see her. At this point, she's like extremely anxious, and she's expecting results from you, and she thinks that you are the only person who is going to let her know what's going on. But now, after 4 hours of testing, make her dizzy, rotate her, even if she's paying, and now how am I supposed to go in front of her and say, you don't have anything? Then she's going to ask me, am I faking? Is it what you're saying? I'm just exaggerating, right? But you understand what I'm saying. So, any reasons why we have this kind of issues? Is it possible, by the way? Oh, yeah. Psychological? Who said it?
I said that.
Okay. Probably. It can be psychological. We never know, right? So in organic structure, we didn't find anything. But let's see what's going on. Right now, I can't answer anything, but I should be aware of this, right? The first thing to remember is, as I said initially, not many health professionals know that there are these kind of tests to find regarding dizziness problems. So this is one thing that we should keep in mind. So first, let's go back in case history. So this also tells you how important the case history is. Are we missing anything in case history? Let's see, it's actually answer is hidden right here. So she had PTSD, we missed that. And the second one, if you observe that this diazepam, which is the anxiety medication, when they gave the diazepam, which is anxiety medication, she also reported that her dizziness is better now. But when we gave the metrazine, which is actual medication for dizziness, it didn't help her. So that indicates that there's no organic issue. So there's no lesion at all. Vestibular system is completely fine, but she had PTSD, which is stress or anxiety, and then when they treated for anxiety, the dizziness is treated. So answer is lying there, but we missed it. Then we put her through all these examinations, and then still the question mark is, we don't know the answer. So that's not the appropriate way to do, right? So that's how the healthcare professionals, even you, me, or anyone misses things, because we always expect that there is something wrong with vestibular system. So this particular scenario or the disorder is called as, right now this name is still not yet standardized because people are still judging. Is it really true? Not, it's like a CAPD, not everyone accepts CAPD, right? Not everyone gets it. So the actual cause for this is the chronic subjective dizziness, also called as psychogenic dizziness. As you're saying, it's psychologically related. And that's why, so coming to the facts, so this is, again, the vestibular system is already overlooked. And even within vestibular system, this kind of diagnosis is even undermined. So most of the people with the dizziness, and 28% of the dizziness report that they have anxiety, and we don't do anything. So right now we are actually trying to advocate for those. And especially people with any of these traits, like anxious, something like me, and introvert like me, are more prone to chronic subjective dizziness. So that's one of the reasons why I get extremely anxious when my flight actually is taking off and I feel that dizziness. I blame my sacral and utricle, or I'm doing wrong job now. It's actually I should blame myself to feel anxious, right? So that's the answer for this. So this is how the regular vestibular disorders go. I just put everything here. I don't know how much sense it makes, but there are a couple of things to take from here. Always focus on your case history. There's always hidden information. Even though clients wants to enhance or exaggerate, or probably want to give you appropriate information, sometimes it can be confusing for us. So in this case, it is clear that how important the case history, right? So I mentioned that she is indicating too many symptoms. So that throws off the audiologist or any professional, or she's telling too many things, but actually, because of that, I missed so many points. But finally, that's what actually showed that this is the actual disorder. So you need to look at those things, never ignore any important information here. Okay, so anyone here, the reason that I said this dizziness topic is because it will and it is affecting a lot of young generation, including me. So when you get stressed, you might feel dizziness. The better way to do is try to reduce your stress. There are like so many things. What can we do? The better thing is to take the anxiety treatment, whatever the medication you're doing. It can be exercise or medications or all kind of stuff. And right now we are also going for osteopathic manipulative treatment. Anyone knows what is osteopathic treatment? So these are like new physicians that non-invasive medications. Basically, they work with joints, muscles, and spine movements, or these kind of stuff, which actually increase more like a chiropractic, all those kind of stuff. So these are the treatment. Okay, I think few take-home things, which we talked about it. Any questions? Am I on time? I think so. Yeah. Yes, please.
Are there any surgical interventions for vestibular disorders? And are those
Yes.
are those ENTs that are?
Surgical, I can do surgery, but ENT is going to do surgery. There are a few indications where like, too much of fluid will be built, then they need to do surgery and then make sure that they disconnect the nerve itself, or probably reduce the fluid, or probably give steroids to reduce that inflammation. There are too many things. Yes, the dizziness sometimes can be treated through surgery, can be treated through medications, and most of the time can be treated through vestibular rehabilitation.
I guess my question is, how many ENTs would operate? Is that a specialty?
That's a specialty, exactly.
So how easy is it to find an ENT who will?
So sometimes these kind of surgeries can also be done by neurologists, neurological surgeons. So it depends. If they are specialized on like neck and throat, then you cannot obviously go there. You cannot know unless they say that vestibular specialist on it, or probably there are like like a migraine, vestibular migraine specialist, or otolaryngologist focus mostly on surgery, but we never know unless they showcase that, or probably your primary care might know about that. Any more questions?
How is the vestibular system affected by aging?
So it's a good question. Do you know anything about aging and cochlea? So basically what I can say is, right now you can look at my hair that I lost my first 25% loss, right? But did I have my hair the same way when I was 18? No. So basically as we age, our whole sensory system, it can be anything. It can be my skin, or my touch, proprioceptive information, ages with us. And the same thing relates to cochlea. In cochlea, the hair cell loses, right? It loses its sensitivity. And even here, the sensors that we talked, it actually depletes its sensation. It takes a lot of movement. Let me go back here, go back fast. So these are the sensors that I talked about. As we age, it becomes like extremely not sensitive enough. So you need to like move on in order to know that you're moving. In that case, if someone is stepping down, your vestibular system is not that active. It tells you that you're actually moving when you're about to fall. So that's how it becomes late. Everything becomes late. They turn late, they speak late, all those kind of stuff. Yeah. Any more? Yeah.
I was just wondering, is the vestibular system linked to the cerebellum?
Yes, exactly. The vestibular system. So we didn't talk about that. When the information goes to the brain, it actually processes mostly in cerebellum. Cerebellum is one of the major important aspect in vestibular system. Yes.
So if you're more sensitive when you're younger, why do younger children tend to like roller coasters more, and as you age, they become less?
The sensitive in the meaning that they also are very sensitive to compensate, and they don't have anxiety issues. That's exactly true. So the intention for children is that they enjoy it. But as an adult, when you see that, oh my God, am I going on to it? Oh my God, I feel nervous. It's your anxiety that makes your brain over sensitive to that. Even though your vestibular system is functioning fine, your brain is expecting some sensation and it is ready to make you go crazy. That's how it goes. Yeah. Okay, great. Last question. I actually thought of putting here as a quiz. So did you like the dog? Did you like the cow? Did you like my presentation? And none of them.
All of it.
Great. All of you.
Huh? Yeah. Great if I run to the bathroom. Man.
All right, 5-minute break. Really quick, if you are a doctor of audiologist, you can raise your hand.
So if you are thinking of switching, go talk to one of those girls.
I never switched. Oh, wow.
Hey, how many?
So my point in the whole story was the three women were standing around talking about how pretty you are.
Awesome. Just a reminder at the end, if you are not looking to get your points, please exit that through that door. And if you are, then go through here and you have to sign out. And then, by the way, we will be sending out a survey probably in the next week because we want to know how you like this event, basically, and we want to make it better. So if you guys can give us some feedback, that would be wonderful. Hi.
My name is Monica Wheat. I'm currently a full-time speech pathologist at Providence Holy Cross, which is just right up the road. Many of you may have driven by. I know one of you knows it very well right now. It kind of feels like old home week for me because here I am in Monterey Hall, like spending thousands, feels like, of hours here as a student, which feels like it was just yesterday. And but I'm reminded that it wasn't because I did my CF with the fabulous Barbara Lang. She was my CF supervisor. And I had many classes with Dr. Seymour. And I actually now it's sort of full circle because I have a student here, Nancy, is my student right now. So it's kind of cool. And I bring it all up because I want you guys really to, you know, I know right now you're students and you're pushing to sort of get to the finish line, however far away that is, but it's not that far and you'll get there quicker than you think. And then you'll be done and you'll think, I never want to set foot on CSUN again. But the truth is you really should. And I want you to think back when you graduate and you walk away about events like tonight. And I'm sure there's many others, but think back about how much you appreciated and maybe you gained even just one thing. And remember that when it's your turn, be sure you give back, okay? Don't just walk away. I know initially you want to run, I totally get it, but be involved with the Alumni Association. You know, give back in any way that you can, okay? When whatever setting you end up in, when it comes time to take students, it's not easy. It's a lot of work for the supervisor to take students, but be the one that says, I'll take a student. Because think of yourself sitting here right now, praying and hoping and wishing for that great placement, right? So give back and you know, you'll learn from your students as well when it's your time. So that's my plug and we'll go on now. So I got the topic of dysphagia, which is cool. I like dysphagia. I like apraxia you know, aphasia as well. Just to give you a little background, maybe you have some background, they have background about me. I worked the last 10 years at Holy Cross. I'm currently on the interdisciplinary stroke team. So what that means is we meet a couple times a week. We talk about the current patients. Obviously, they're all stroke patients. And I give my part, which is really a huge important part. But then there's an OT there, there's a pharmacist there, there's a social worker there, there's the neurosurgeon there, or the neurologist there. So it's kind of a cool team to be on. And so we talk about swallowing and speech and language and cognition and all the other components that put the patient together. So that's one of the parts of my job I really like. Anyway, let's go on with tonight for you guys. So this patient that I hope that you'll learn something from, he is a 68-year-old male. He was brought to Holy Cross by helicopter. He presented to the ED awake and alert, talking, but he had acute left-sided weakness, left facial droop. He did have difficulty speaking, but he was speaking. And his voice was faint, described as faint and hoarse. These are not my descriptions. This is actually taken right from the intake from the ED, okay? The patient at the time reported 3 out of 10 lower back pain and mild dizziness without nausea. Okay, so 3 out of 10 pain, are you good with that? You know what that means? 0 is no pain, 10 is the worst pain you've ever had, so 3 is bearable, right? Okay, okay. All right, and what about, he had a heart rate of 114, he had respiration rate of 20, blood pressure of 98 over 65, and a Glasgow Coma score of 15. So my question to you is, first one, what are normal heart rate, respiration rate, and blood pressure? Oh, there's a lot of mumbling. Someone, yes.
I'm gonna give it my best shot.
Go.
So I think normal heart rate is around 60 to 80.
Okay.
Normal respiratory rate is, it varies for women and men, but around like 9 to 25, around that range. And normal blood pressure, people say is 120/80, but it's different for every individual.
Right. Nice answer. Very well done. If I had candy, I would throw you. There it is. Like, you know, there's no calories involved in that one. Okay. All right. Nice job. All right. We're going to hold on to that. Now, what about the Glasgow Coma score? I know you guys go over that because we did it when I was here.
That's the best possible.
15's the best. Yeah. It is. So what does that mean? No deficits, or the higher the score, the better, the lower the score, the better? The higher the score, the better. So 15 is the maximum score you can get. That means they're not seeing anything wrong, right? What's the lowest score you can get?
3.
Right. And what are the 3 areas that they look at when they score? Because there's 3 different components. Yes, go ahead.
Awake,
Yeah.
alert.
Okay, good, nice try. All right, you get like half a candy. Okay. So I'm gonna come back to that slide, but I want you to see this. So the blood pressure categories, the biggest one, and I'm gonna go to you. You said 120/80, and you were really right on. That's right now the guideline, kind of the general guideline for everything. If you're higher than that, and then you start to become hypertensive. If you're lower than that, you're hypotensive. If you're 90/60, you're considered really, really hypotensive. And these are things are important to us when we're looking at, is it a good time to evaluate my patient? How is this maybe affecting what my evaluation is going to look like? But you can get this from the American Stroke Association or the American Heart Association. That's exactly where this grid came from. Normal heart rate, excuse me, 60 to 100 beats per minute. I think you were a little off on that. That's okay. Good guessing. Now you know. And then normal respiration rate, 12 to 18. So like a really fit athlete, their normal respiration rate is going to be lower, right? And somebody who's maybe overweight with COPD, their baseline respiration rate is going to be higher. But these are the norms. So this is important information if you're working in a medical setting, because you need to kind of have a feel for, oh, his respiration rate is 45. Maybe he's a little stressed right now. It might not be the best time to give him a drink of water. Let's calm down first, right? So that's why I bring it up. Then this other one, I don't know how far my tether is. Okay. The other one is the Glasgow Coma scale. And you're exactly right on, nice job. But the first one is about the eyes. The next one is about the mouth, the verbal response. So it's an alert. It's kind of what you said. And then the next one is more of a verbal response. The last one is motor. So kind of think, if you're thinking of the Glasgow Coma, I think eyes, mouth, and motor. Like.
So I just want to verify, I get a whole candy and Joey gets half.
Yes, that's correct.
Okay.
That's correct. Yes. Yeah. Sorry, Joey. Maybe next time. Yeah. All right. Good. So I want to go back to this now that we kind of got that out of the way, and think about just looking at these basic signs and symptoms. What are you guys thinking might be going on with this patient? Just given this little bit of information. Raise your hand, big up high. TBI? Maybe. Stroke. Right hemisphere stroke. And why do you say that? Okay, good. All right, nicely done. Okay, so here's some more about previous medical history. So what I gave you just then was basically the chief complaint. Why did he come to the hospital? Because he's got this acute sudden onset deficit, right? Left-sided weakness deficit. So here's what's going on with him prior. This is his sort of like, think of this as his baseline, okay? Esophageal cancer, diagnosed in 2019 with metastasis to both lungs. Chronic AFib with blood clots. hyperlipidemia, which I put in there high cholesterol in case you guys didn't know, thyroid disease. He's hypothyroid, meaning his thyroid does not make enough, versus hyper, which makes too much. And discharge from UCLA 3 days prior to his admit with us after diagnosis of blood clots in the legs. So that's where he came from, right? Is he a healthy guy? No, he's not a healthy guy. He's actually a very unhealthy guy. But the truth is, he's esophageal cancer diagnosed in 2019. And that's actually an error. When he came to us, he was diagnosed 6 years prior. So that should really be 2014, okay? And the reason I'm bringing that up is that is amazing that he's lived that long with that diagnosis. That's pretty incredible. So, but you know, that's the person we come. So now what do we have? We think this person has had a stroke, a right-sided stroke, and we know he's really sick at baseline, right? He's got esophageal cancer, which is more interesting to us, right? Okay, good. Everybody know AFib? It's like, you know, irregular heartbeat. Good, okay. Okay, so I put on these medications here. I know that at CSUN and probably every program, I don't think, you guys don't really, we didn't go over medications very much, right? It's like we didn't really talk about that. And I didn't learn anything about medications till I was actually in the hospital setting. But I'm bringing it up here, not because I expect you to know this, but because I want you to appreciate how important medications are to our work and that what an impact they can have on our work, okay? And so even though it's not something we're diving into right here at CSUN, if you end up in a medical setting, it will become important to you, or it should become. And even if you're in the school, what about this kid that's, you know, on some kind of meds for his CP, or what if he's taking Ritalin, or what? There's a million things, right? I mean, meds are important to us if you're taking them or you're not taking them. So it's an important consideration. And so when we're doing like a chart review in the hospital setting, we should be, if you're responsible, you should be looking at medications and taking that all into consideration. Just generally now, this is more, again, I don't know how much you know or don't know, so it was just like a broad, you know, many medications actually cause dysphagia just themselves. Our patient may not have any dysphagia and they start taking this med and it brings on dysphagia, or it causes them to start coughing continuously. Lisinopril is a great one. It just, they cough, they can't help it. It's just one of the side effects. And so now we're thinking, oh, you're coughing with intake. No, has nothing to do with that. It's all that med, right? Okay, so just in general, narcotics, they decrease awareness, obviously. They decrease voluntary muscle control and cause difficulty initiating the swallow. So if our patient just had codeine, just had a nice big dose of it before we got there, or morphine right before or maybe 10 minutes before we got there, perfect, great. Here I am, swallow valve. Let's talk, you know, let's get our speech language eval in, right? And do you think it's a good time right then? No, heck no, it's not a good time. Like, you should come back probably, because you're not going to get the real picture unless this person is an addict and they're not affected by it, because we have that too, right? But I'm talking about generally the average human who just got a big dose, they might be affected by that. So you should take that into consideration. Corticosteroids, high doses cause skeletal muscle wasting of the esophagus. That's over time, but again, if you have somebody coming in, maybe they're a bodybuilder and they've been on steroids for 15 years. That's something to think about, right? Antibiotics and aspirin. This is more like, it can sort of give the symptoms of, it's called medication GERD, where it makes you reflux because it causes this interaction in your stomach and you get acidity. Some people are more sensitive than others, and then they just start to reflux. So now we come in and we think, oh, you have reflux. They don't have reflux, it has to do with their meds. They have it at this moment, but it's not a chronic condition, right? So those are just a few examples. I want you to just be thoughtful about meds in whatever setting you're in, and don't just think it's medical setting that has to worry about it, okay? Okay. So case history, let's talk some more. So we had some previous medical history. We know why he came. And now we look through the meds. Now we're looking through the chart, right? And we look at imaging. So the first thing we come across is the CT head. It says right frontal probable meningioma with surrounding right frontal edema. Bummer, right? Right. Yeah, scary. Okay. So what do we know? We know he had esophageal cancer. We know he had mets to the lungs. What's he got now? Mets in the brain. Okay, so next, MRI. Sometimes they'll do the CT typically first because that can detect an acute bleed better than an MRI right away, and then later on the MRI detects more. So sometimes things will show in the CT and they won't show in the MRI, or they'll show in the MRI and they won't in the CT. All right, so I believe this might have been done the same day. Oops, sorry, I shouldn't put my hand in front of the microphone. I think these were done the same day. So the MRI, multiple necrotic hemorrhagic masses in the right frontal, parietal, occipital lobes, and in the right cerebellum. Highly suspicious for mets. So he's got them. They saw a few in the right frontal in the CT, but then when you got to the MRI, we saw the whole battery of them. Evolving acute, and also on top of that, evolving acute infarct with hemorrhagic transformation noted in the right globus pallidus. So sure enough, we were right. He did have a right stroke, right? So we were thinking critically, we were thinking correctly when we're reading. We can find out a lot even before we look at the imaging. Sometimes our imaging is not available when we do our first eval, right? Our initial eval. And for some people in some settings, they never get to see the imaging, right? So it's really important to take whatever information you have and use it. So what deficits might you expect to see in this patient given these imaging results? So think about this for a second. There's so many areas of injury, right? So we know he had a stroke and that affects the right globus pallidus. Where is that? Yes, ding, ding, ding. Candy for you. Okay. Who was it? Good job. Yeah, nice. 2. I threw 2. Okay. And so what does that do? Say it again. Yeah. Yeah, but tell me something. Is there anything that it does that you might think, is going to affect your swallow valve? Yeah. 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 Okay. What about all these mets? Because they're not just sitting there, doing nothing, right? They're affecting the area that's there. Even though that's not the reason that he came into the hospital, we're still interested in that, right? Because that's going to impact our clinical picture. What it could impact what we see, right? So you can't just say, well, I found my stroke, I'm on my merry way. So let's think about and take down each one of those areas. So the right frontal mets. Let's think about the frontal lobe. Possible deficits in motor function, right? Because we've got the motor strip right there at the posterior end of the, yes?
Sorry, I have a random question, but what does
metastasis?
mean?
Those are cells that broke off from the original cancer and have found their way to new tissue. So the original cancer was in the esophagus. So cells would have taken off from there and found their way to the brain and to the lungs, okay? So oftentimes you'll have a cancer patient, their primary diagnosis was maybe brain cancer, but they end up with lung mets because the blood system just takes it down there and they're happy to grow anywhere, many of them. Yeah, good question. So speech, of course, we're worried about speech generation in the frontal lobe, right? Right? So we might expect that there's a problem with speech just because of that, not because of the stroke, right? Okay. Executive function, so that's planning, reasoning, problem solving. Okay. Short-term memory, regulating emotions, excuse me, motivation, response inhibition. So a lot of these patients will be very forward and have no barrier. They have no filter. They say what they have on their mind, right? Honey, does this shirt make me look fat? No, no, honey, you look great. Frontal lobe, that makes you look fat, right? That's the difference. I mean, they just say it like it is. Changes in personality and visual attention. There's actually some visual fibers. I know vision is elsewhere, but there's actually a few fibers that go up there. And so it's more of an attention, a visual attention, more than an acuity. Okay, so that's it. Then on the MRI, it saw the right frontal mass, so it's as above. Yeah.
So you could see like articulation problems with the right hemisphere stroke.
Well, yeah.
I was just curious.
Yeah. Okay, so right parietal mass. What's it say? Possible deficits in proprioception. So when you think about the parietal lobe, you're thinking about their ability to detect themselves in space, right? Sensory input from the skin, cognition, thinking, calculation, so that dyscalculia comes in, spatial neglect, and anosognosia.
So they will probably struggle with that clock, because I know there's the eval for the clock.
Mhm,
They'll probably struggle
yeah.
with those numbers writing them
They
down.
might very well with parietal lobe, yes, they might very well, yeah. Okay, cerebellar mass, that's again another mass. So where's the cerebellum? In the back. Okay, what does it do? You guys just heard about it in the talk before, right? Balance, right? So there's 3 lobes in the cerebellum. There's like an anterior lobe, and then that middle lobe is flocculonodular, I think. And then the back lobe is posterior, and then there's a center section, right? So it's like 2 little brains, and then the center section. The center section, that's the place where most of the balance is, and I think that's the area where you can, if it gets a, no, sorry, I'm telling you wrong. Balance is where in flocculonodular. Balance is in flocculonodular. The center place is, you can get, that's pseudobulbar effect. Okay, that's the emotional place where if you see these patients that they cry at everything or they laugh because they're at things that are inappropriate, crying and laughing inappropriately, that happens because of that area of the cerebellum. So balance is the center. Yeah. All right. Where else? The right globus pallidus. Okay, let's talk about that. Possible difficulty with I said dysarthria already. You talked about motor. That we're on the same page there. Okay. But it's more the volitional swallow too. About that part of I want to not the involuntary part. That's back in the basal ganglion. In the brainstem, thank you. I had basal ganglia in my head. So this is more the involuntary part, okay? All right. Questions? Okay. Okay. So besides the CT and the MRI, we have a chest X-ray. We're usually looking at that because, of course, that particularly pertains to swallow. We're particularly looking for infiltrate. In his case, what are we expecting to see in the chest X-ray? Mets. Okay. So we see retrocardiac atelectasis or infiltrate, and right lower lung field mass and left upper lung field mass. So I think our case history said bilateral lung cancer, lung disease. It shows it here. And the atelectasis retrocardiac means kind of behind the heart. Are you guys familiar with those terms? Okay, so infiltrate, well, atelectasis is the little alveoli. They can sort of collapse or even become filled with fluid, and then they can make the whole lung either partially collapse or completely collapse. So when that happens, that's what they're referring to as atelectasis. Infiltrate, that can be blood, pus, protein of some kind. It could be food, you know, right down in there, but it's not necessarily food. In his case, it could be a frank mass down there, but they're seeing, they really see the mass. They can usually identify the mass. There's been a few instances in patients where, you know, I've had the neurologist will say, I can't really tell on this chest X-ray, like, is this the mass? Is this infiltrate? Is this we can't tell. So in this particular patient, they could differentiate, but they couldn't differentiate, is it atelectasis or infiltrate? And that's common. Like, we see that a lot. That will happen a lot. Okay. So now the patient also has elevated white count. He's tolerating room air, so he doesn't need any O2, no high flow, no nasal cannula, nothing else. He failed his swallow screen, and the Yale swallow screen is what we use at Holy Cross. The nurses give it, and it is a pass-fail. Do you guys talk about it? Basically, they give them 3 ounces of water. They judge their cognition first, and then they give them 3 ounces of water, and you have to serial take it, either by cup sips or straw. And if you don't, then it's a fail. If you have any signs of airway penetration, then it's a fail. If you're not able to do it, it's a fail. And so it definitely is a pass-fail test. And at our hospital, if they pass, then the nurses, if they feel comfortable, will put them on, start them on a diet, but they might still order us. If they don't pass, then they're made NPO, and they for sure ask for speech eval. So let's see. Okay. So anything from this information that you are thinking about? Yeah. Okay, so I'm thinking about the elevated white count. Like, why does he have that? Because you were going to say?
Infection?
Yeah, I mean, that means, does he have a raging infection somewhere? Is the infection in the lungs? Does it really infiltrate? Does he have a pneumonia? Or is it somewhere else? Certainly this man riddled with cancer could have an infection somewhere, right? He could be, you know, having a response to all the cancer he has, so that's not that unusual, but it's worth taking note of. And then the other thing that's important here is just, again, the respiration. How many minutes? 10 minutes. Okay. Oh, that goes so fast. All right. His need for O2, he doesn't need it. So he's, believe it or not, with all that cancer in his lungs and the stroke, he's still on room air. That's pretty amazing. He's 68, you guys. It's amazing. So that's impressive. Okay, so SLP Initial Assessment. The therapist that did the initial assessment would do an oral motor exam. Usually we'll look at voice, and then we'll do PO trials. And this is a bedside swallow eval, okay? So first one. Are you guys do this? When I was here, we did not do, we had a whole different swallowing program. So tell me how much I know you do the MBS-IMP, but are they talking a lot about the clinical swallow and kind of the bedside oral motor? So this is not new to you then? For the undergrads it is, but for the students that are in the program, it's not. Good, thank you, good, that's amazing. All right, so I just gave some examples of the things that you would be doing in order to test that cranial nerve in the oral motor. We're looking at though, I mean, that's the 5 cranial nerves that are involved with swallow. So I don't think I'm gonna go through each one. I don't think it's necessary. The only thing I put in caps, left facial droop, left labial weakness, asymmetric pucker, and decreased lingual strength were the things that were of note, okay? And then in voice, patient is hypophonic, whispered, somewhat hoarse, very low intensity, making it difficult to hear a patient even when you're standing close. right? That kind of makes sense. And it ties in with what they said from the ED, oh, his voice is faint, right? Okay. All right. So the only thing I'm going to ask you here is maybe the last question. If the uvula is deviated on ah, what does that mean?
Vagus nerve is affected.
Vagus nervous. And where's your deficit?
On the opposite.
Deviates to the weaker side.
Thank you. Yeah. Deviates to the opposite side. Yeah. Deviates to the opposite side. Did I hear it right? Somewhere over there. I'm throwing you candy. Somewhere.
Is the only one that doesn't deviate to the weaker side.
Deviates to the weakness on the opposite side. Yeah. All right. What's the other question I asked? If the tongue deviates upon protrusion, what does that mean?
Damage to 12
Yeah.
Or
And
7.
cranial nerve 7.
Yeah.
Who thinks 12? Who thinks 7?
12.
12.
Muscle.
12. Yep. And if it's if they stick their tongue out and it's deviating to the left, where's the damage?
Left.
Wait, that's all over. Okay, so on the tongue, the deal is if it's an upper motor neuron injury, then it will deviate to the contralateral side. If it's a lower motor neuron injury, it will deviate to the same side. Right? Right. Okay. Okay, gave them PO trials, thin liquid, cup sips, inconsistent weak dry cough after some spoon and cup sips, tolerated nectar without any difficulty, tolerated pudding and diced fruit and cracker, he refused, stating his baseline diet is basically soft, so he refused that. All right, so now what do you think? You've done your oral exam, you know about his voice. What do you think?
Conduct an instrumental evaluation to see where it is that his swallow is breaking down.
Okay. And would you put him on a diet?
No.
No. Do I have anyone?
Go ahead.
No.
If someone wants.
Yeah. Would you put him on a diet? Hannah?
No, not until an instrumental.
Okay. No. Anyone else? Yes? Yes?
Well, at least say no thin liquids, tolerated other stuff.
You'd say no thin liquids? And he tolerated the other stuff, so what would you put him on? Thicken. You put him on, you put him on nectar and puree? Sure. Okay. All right. Okay, so here's the deal. This is a person who wants to eat, right? Like any person, any of us, if we were sick or in the hospital, we want to eat. So you better be darn sure about what you're doing. If you're denying this patient food, you better be sure that you're on it and you're really doing it for a reason. Or if you're giving him food, you better be sure about what the consistency is you're limiting him to, right? Okay. Then I assume then most of you would pick them up for treatment. We're not finished because you're saying do an instrumental, right? Okay. So what if I added this to your clinical picture? Okay, before you did any of that, what if I added this in? And I told you that the patient was diagnosed with stage 4 esophageal cancer 6 years ago. There's my 6 years. With recent diagnosis of mets to lungs and brain and second esophageal growth. Chemo and radiation with last session was 2 months ago. Baseline intake is soft, mostly ground solid, and thin liquid diet with greatly fluctuating appetite and inconsistent cough with thin liquids. This is the report from the family. He had a vocal fold injection 1 year ago to medialize the fold, but unsure which vocal fold was involved. And the patient stated, "I'm due for another." Get right in there. No history of pneumonia, but ongoing cold for last 3 weeks. Recent admit to another facility for cardiac symptoms. Okay, so now that you have this layer of information, how does that change anything for you, or does it?
My concern is the second growth.
Mm-hmm. Okay. So it's spreading. Mm-hmm. Mm-hmm.
Also,
Yeah.
we learned that radiation can cause a lot of problems with range of motion.
Right, right. That's entirely true, and oftentimes it doesn't happen right away. Oftentimes it's 5 years down the road, or even 10 years down the road, or 15 years down the road. So sometimes the initial burn and all of that, but once that's healed, they're like, yeah, I'm pretty good. And then 5 years later, they have terrible dysphagia.
Had it 6 years ago.
Right. We don't have a good history about all the treatment that he had. How am I doing?
Oh,
I'm out of time.
I wanted to know. Answer.
Oh, yeah. Please answer. Please answer.
With the second growth in his esophagus and the need for a vocal fold injection, I'd be scared about his airway protection and possible reflux of anything that he might swallow with nectar and puree.
Yeah.
So
Yeah.
I'd probably put him on NPO.
You make him NPO
Yeah.
and have him
And have him get an instrumental.
Yeah, yeah. Okay. I love hearing all the NPO. This is a patient that I did not initially do the eval on, but I had a long discussion with the therapist that did. So I'm gonna put this up here. This was the analysis. This is just from the bedside now. Patient presents with mild oral impairment marked by overall weakness and suspected pharyngeal impairment. Recommends starting a ground consistency with nectar-thick liquids, ongoing therapy. Given patient is full code and aspiration risk is significantly elevated, highly recommend video swallow to delineate function, yada, yada, yada. Patient says he does not want to proceed with the study at this time. The SLP provided copious education and extensively reviewed his aspiration risk. He acknowledged and said, yeah, I get it, but I'm tired of doing studies and I don't need it. The wife wants him to have the study. Whose body is it? Who gets to choose? He does. He does. Unfortunately, when he gets to the point where he can't choose, then she does. And if she doesn't honor his, that's a whole nother discussion for another day. But it does happen. So there's a lot of conflict here, right? And this therapist was like, crap, what do I do? The guy doesn't want any studies, except he's full cut. Like he wants us to do everything for him, but he doesn't want us to help him. Like he's refusing this study. Where are his mets? That's what I'm going to ask you. In the frontal lobe. Is he making good choices? No. Probably not. But he still is, his own decision maker at this moment. So he's probably not making, maybe he's not, I don't know. We don't know for sure, but maybe he's not making the choices he would have made without those. We can only suppose. But this is why all of this information is so important for you to take it and really, really use it, because it impacts everything you're going to do. Okay, so all we can do is say what we think. All we can do is give our best clinical judgment and say, this is what we think we want to do with you. If you're not willing, then okay, we want you to eat. My God, you're filled with mets. You might die tomorrow. I don't want to make you. There's all of that too, right? So the guy did tolerate nectar thick without coughing, right?
Wow.
Okay, that was on our bedside. That we haven't done it. That was just on the bedside. So, all right, let's start him on something. He doesn't want to do the video. He's firm about that. We're not just going to make him NPO. He wants to eat. He knows the risks. We've educated him. The wife knows the risks. So, okay, we're going to go forward. And the plan was, we talked about this patient, and the plan was, all right, I'm going to go see this patient the next day and do my best cell job to try to get this patient on board, to try to do a video swallow. We're not going to give up. We're going to pick him up and treat him. We're going to start him on a diet. Is that the right, it's the right thing in this circumstance. Okay, and that's why I brought this case up to you, because it's like Dr. Jackson used to always say, Katherine Jackson, it's just not that simple. She was a professor here. Did any of you guys know her? Yeah, she's amazing. Yeah, amazing, amazing. And she would stand up right here and say, it's not that simple. And this is a great example of that. So you have all the knowledge, you have all this, you know, you've studied really hard and you know all this stuff, but when you get out there in the real world, some of these decisions that you have to make aren't that, it's not black and white. There's so many other factors that come into it. And it's not our body, it's their body, right? They do get to choose. We just are a consultant along the way to give our best medical opinion and give the information that we know. And then they get to make a choice. So she started him on that on the first eval. The next time, head to the room, take ice chips, take thin, take nectar, take puree, take a variety of foods, and think, crap, I think this guy's aspirating everything, but who knows, you know? All right, so give him ice chips and nectar thick liquid by cup, and he tolerates without any overt signs and symptoms, okay? Ice chips and nectar, he tolerates again without any signs. On thin liquid, the initiation, he's kind of, it feels delayed, the initiation of swallow feels delayed. Now, we all know that we don't really know that for sure, bedside. We can only comment. So like when I comment, I'll say, initiation of swallow is perceived to be delayed. I'll say perceived, or I used to say judged. I don't like that so much. I like perceived. Like it sounds like, look, I'm judging from the bedside. I do not have x-ray vision. I'm saying what it looks like to me, what's happening, but I don't know. But it gives me a reason for wanting to do the video swallow, right, or the fees. Inconsistent cough after swallowing thin. So he tolerates a bunch of it, and then there's a few that he coughs after. And his cough is non-productive, as you might imagine, right? Because he doesn't have vocal fold adduction, so he can't clear anything. Okay, diced fruit, weak, dry, non-productive cough again after 1 out of 5 trials. Why do you think that might have been with the diced fruit? Think about the thin liquid. There's your big clue.
Yeah.
Why?
It's easier to manipulate.
Now, why do you think he would have tolerated 4 out of 5 of the trials of diced fruit, but he had signs of airway penetration on one? Because of the juice. Yeah, right. Because what is it? It's thin liquid. Right. Okay, so we go through all this. Now remember, he's on ground and nectar. So have a nice education. So talk about video swallow, talk about the reasons why. Not trying to dissuade him, trying to be very respectful that he gets to choose, but still trying to provide education the next day. You never know. And sure enough, he came around and said, okay, I'll do it. Cool. How quick can we get it done? Do we have fees? I have the fees in there. We don't have fees yet at Holy Cross, but it's coming. It's coming. Scheduled got the order. Got to get an order from an MD, right? And scheduled the video swallow for the next day. And at that time, I left him on that diet. I could have made him NPO, but he was still tolerating some. Okay, you know, what's one more day? Well, you know, you want to eat. Okay. All right. So, wonder. There we go. So this is the first trial of thin. Nice, huh? Mm-hmm. Okay, I'll play it again so you can see.
Monica?
Yeah?
A couple more minutes.
What?
A couple more minutes.
Okay, okay. Then I'm not going to play it again. That's normal. This one is thin liquid, like a few more cereal sips. Mm-hmm. What do you guys see?
Residue.
Yeah, molecular residue. Okay, this one is thin liquid. This is with a few cereal sips. It's just an image. I stopped it here. You can see the penetration. You can see the molecular residue. He's got piriform residue. He doesn't have good base of tongue retraction. He doesn't have good hyolaryngeal elevation. And remember, his vocal cords are open, right? Okay. This one's nectar thick liquid. Right? What's he on, by the way?
Nectar.
Nectar. What did he tolerate bedside? It's another reason I brought this for you guys. And he frankly coughs. It's not silent there, but bedside, he's aspirating on it, and it's silent. He's just tolerating it, no problem, right? And here it's, oh yeah. So instrumental. But again, this is a good case because not everybody's going to agree with you. So then you have to kind of go along for a little bit and try to ride the wave. Okay. Okay, this one is just dry cracker, just for you to see. So see, he's still got all that residue up on the epiglottis. That's all that's still from the puree. It's sitting there on the, I think it's on the posterior aspect, and it's just this blob of puree. And he's not clearing that molecular residue because he's not elevating. His tongue isn't retracting. So we tried chin tuck, even, nothing's going to clear that off. I don't know whatever happened to that little piece of puree, but so thin liquid material. Now we're using the PASS scale. I'm not going to go into that then. Yes.
Do you usually do esophageal sweeps?
Yeah, not our. We do not always do them, but we do them. But it's not an always. And I will say that, let me go and to speak to that. Not everybody is MBSIMP. So we will use the grid, but we don't, the ones that well, I think there's only one person that is. And then she sometimes will use the grid from MBSIMP. The rest will not. We'll just comment on those areas. So there's a lot of room for improvement everywhere, but yeah. Good point, Hannah. Okay, so thin material doesn't enter the airway. That PAS scale, it's the penetration aspiration scale. You guys can check it out on your own. Basically, you score every single trial you give, and it gives you 1 is the low, and I think 8 is the. Yeah, 8 is the high, and 8 is just frank aspiration down. Okay, and it's so then you score every single consistency, and it is a nice way so you can see quickly here, like, oh, past 7, that's the consistency he did the worst on, right? Nectar thick liquid, non-silent aspiration below the vocal cord fold and not ejected. Okay, so after the video swallow, what are you recommending? Puree? Sorry. Solids. Which solids? Right. Okay, if he can, you're absolutely right. And what about liquids? Okay. She's saying free water protocol, and then what are you doing for regular liquids throughout the day? Like with meals? Thicken? Right, and what are you guys doing? What are you guys doing? What are you doing back there? Not what are you doing? What are you doing? What do you think? It's not easy, is it? No. Yeah. She's going to give him a G2.
No, I mean, that's up to
yeah.
decision,
Okay. No,
it's a choice.
It's a choice.
Probably wouldn't like that.
Okay. So a couple of things. Think about this guy's quality of life. Think about his overall prognosis. Think about that he wants to eat. And look at your video swallow results. Single cup sips of thin liquid did not enter the airway over multiple trials, serial sips, and actually I take that back. On serial sips, it entered the airway, but it was ejected. So here's the other thing. If you start him on, I'm going to come. If you start him on nectar thick, and he aspirates that, what would we rather him aspirate? Water or thin, at the very least, right? We don't want him to be aspirating nectar thick if he's going to be aspirating anyway, right? And he wants to eat. He doesn't want to be NPO. He doesn't want a G2. He's made that clear. So okay, you want to eat, fin is the way to go. So we're going to be very conservative and give really strict swallow precautions and say, you know, effortful swallow, single sip, no straws. Yeah.
Did you try any postural?
We tried chin down, yeah. And the other thing is, I haven't relayed that very well here, but he's extremely weak. He can sit up. He does hold his own torso up, but he's very, very, very weak. And again, he's got no voice. He doesn't have a good way to cough. He doesn't have good endurance. So when he takes a meal is about 3 to 5 teaspoons of liquid and a couple of teaspoons of some solid, and then he's done, right? So it's a good thought, a totally good thought. And we did try with him, but it didn't do anything to clear any of that. Yeah. Okay, so are we finished with him? What did we decide to recommend? Yeah, we're putting him on fin, we're putting him on ground, because that's basically what he was having at home. It's mostly, yes, can he chew, to come back to your comment about, well, he can chew, he ate the cracker. But the thing is, you want to think about the whole meal. So can he get through a whole meal of solid liquid? No, he can barely get through a meal of liquid. He's just going to get too tired. So we stuck with the ground because of that, right? To try to encourage quantity. But good thought, totally good thought. Okay, so are we finished? Are you recommending anything else? Done, last one. You think we're good?
Swallow it there.
I'm just worried he's not getting enough calories.
Right. So that's where dietary comes in and says, you know, he needs to have this boost or this formulation and make him take this first over anything else, okay? And my last slide, I promise. The patient does not appear appropriate for aggressive dysphagia treatment, right? Look at his whole prognosis. I mean, if he was appropriate, you know, we're saying please use these strict swallow strategies and stay on fins, but under these conditions. And then if he was appropriate, that's why I put this on here, I probably would do CTAR with him, chin tuck against resistance, to help with hyolaryngeal elevation. And I would probably start with the Masako for the base of tongue. Those would be the 2 things I would start with, but I'm not starting with it with him because he's too weak. He doesn't have the endurance to even do 1. He cannot, but that he doesn't have the endurance for it. Okay, but I wanted to agree that there would be treatment in theory. And then I'm recommending an ENT consult, right? To delineate the vocal fold pathology. If he's gonna, you know, yes, okay, let's say you've lived this long, maybe you have 5 more years. Let's have an injection. An ENT should look and see what's going on here with that. See, maybe there's a new growth higher up on the vocal cord. I don't know what's happening with the voice now. That injection was a year ago, right? We don't know. He's got active cancer. So he needs to see an ENT if that's the path they're going to follow. The last thing is he needs palliative care consult. So palliative care, you guys familiar with that? Do not call it hospice care ever. Do not ever call it hospice care. It's not the same thing. Okay? Promise me. Okay, so palliative care looks at like the whole being, the whole person, and they look to improve the quality of life. So at Holy Cross, we have this amazing palliative care MD. It's a woman, of course. Sorry. She's really amazing. And basically, she's an adjunct to all the other MDs. And she goes in and says, okay, let's look at your whole clinical picture. Let's look at everything that's happening with you. Because we all know the cardiologist goes in and says, I'm going to talk about your heart. And the pulmonologist comes in and says, I'm going to talk about your lungs. And the oncologist comes in and says, I'm going to talk about your cancer. Okay? Nobody is looking at the whole being, right? But the palliative care MD is. So they work with people that have serious illness, not terminal illness, although it could be terminal, but they're serious life-threatening illness right now, and they may have a good prognosis for getting better, they may have a poor prognosis and they're not going to get better, but they can still be on board. Hospice is, you know, I'm headed up to the Rainbow Gate, the Rainbow Bridge, sorry. All right, okay, so that's the difference. So that's what I would recommend for him, to get palliative on board so that he and his wife can have a discussion about his whole care and really dive into what are his goals. Okay, that's it.
Yeah, I did all of that with anyone else.
Make sure you sign out if you want your points. We're gonna have our second round in 2 weeks, pediatric round, and then we're actually gonna have a feeding and lactation panel in March 24th. So keep an eye out for that. Thank you.
Not yet.